Um, Hi, everyone. My name is John Simwanza. I'm going to take you through the outbreak investigation of COVID-19 cases at a school in Kafue district that we did in May 2021. So throughout the pandemic of COVID, we've come to know that congregate settings and closed settings like schools and workplaces can exacerbate the spread of COVID-19. I think we are also privy to the information that with regards to children, COVID did not affect them in the earlier phases of the pandemic, but this has changed as the pandemic has evolved. We therefore conducted a study to determine the factors contributing to the increase in SARS-CoV-2 cases at a school in Kafue in order to prevent and reduce transmission of disease among the students and the staff at the school. So what we know about this outbreak is that initially there was a cluster of 4 pupils that presented with COVID-like symptoms that necessitated their testing. These cases were from grades 10A and 10B and were brought, and the age ranges were between the ages of 15 to 17 years of age. And the follow-up of all the people at the school was made. And from this follow-up, we had about a 30% positivity that came through. That's about 138 people were actually positive. So on further probing of the symptomatic cases, we found that the index case could have been a male aged 14 years of age who reported to have had symptoms 8 days prior to the first reported case. There were no risk factors like travel or contact with positives and others associated with this case. A total of 15 pupils were symptomatic during the period of follow-up and were distributed as shown in the EpiCurve. So what were our objectives? Our objectives were to investigate the upsurge of COVID-19 cases in a school in Kafue. We also wanted to confirm the outbreak by targeted testing of all the pupils and the teachers at the school. We also wanted to describe epidemiologically the COVID-19 cases seen in the school. We also wanted to find out what variants were actually circulating during this outbreak and to determine what risk factors could have led to the outbreak. And ultimately, we wanted to ensure that we make recommendations to minimize the spread of the infection in the school. So during the follow-up of the cluster of positives that I earlier mentioned, everyone was tested at the school using PCR, as most of these were asymptomatic and some were to be selected randomly for genomic sequencing. So you realize that the policy that we have is that for symptomatics, we can use RDT, but for this case, we decided to use PCR for most of the, for all the people that we were seeing because of the genomic sequencing, and for most of the people that we were seeing, they didn't actually exhibit any symptoms. So after follow-up, in order to try and find the risk factors, a case control study was done with a case control ratio of about 1 to 3. That's cases to controls. A case being defined as any pupil at the school who was tested and came out positive for SARS-CoV-2 using PCR, and the control was any pupil that was tested at the school using PCR and came out negative. We did a bivariate analysis so that we could see the factors that were significantly associated with positivity. And then the ones that were significantly associated with positivity were the ones that were selected for the final multivariable logistic regression model that we did. Samples were randomly selected for genomic sequencing. These are the variables that we looked at. We looked at sex, age, dormitory, history of contact with a positive, leaving school prior to testing, attendance of meeting with more than 10 people, number in class, and church attendance. So to establish the extent of the outbreak, as all the classes were affected, we tested all the people at the school. 2 positives were non-pupils, and these were followed up separately, and contact tracing was done. With a population of 393 pupils and taking a confidence level of 95% with a 0.05 margin of error, the calculated sample size was 195. The final sample size was about 97% of the calculated sample size. So on the demographic findings, the median age was about 14, with more males than females, and an average of, or a median of 34 in each class. We also saw that there were about 15 out of the 136 that were symptomatic. So these are the ones that were earlier alluded to when we looked at the EpiCurve. So one person, one pupil from these was actually hospitalized for 3 days. There were no deaths that were recorded. The one that was hospitalized was not critical and didn't need any oxygen therapy. Analysis by class, the highest class to show positivity was grade 10A, and this was based on the number of each section. So we, to find the positivity, we divided the number of positives divided by the total number in class, and the least was the teaching and non-teaching staff. All the samples that were sequenced were found to be the Delta variant. And when we looked at factors that were associated with positivity from the different variables that we had run bivariately, we found that only 2 were significant. That's grade and attendance with more than 10 people, attendance of a meeting with more than 10 people. So we, if you see that the only significant ones in this case were the attendance of more than 10 people, a meeting with more than 10 people, and the 2 grades that are highlighted. So one of the limitations that we found when doing this study was that there was non-availability of all the pupils that were randomly selected for the study. That's why our final sample size was about 97% of what we had originally planned. Interview bias, as the interviews took place during the outbreak of at the school, could have caused a distortion in questions like history of a contact with a positive, as almost everyone responded in the affirmative to this question. And it was difficult then to see if this was truly something that was not significant to the findings. Then we also excluded the teachers from the interviews, as the questionnaire was designed to gather data about the pupils, like class, dormitory, age, number in class. So this would have been distorted if we had included the teachers. Then the initial cluster of cases were gotten by their parents, but with intervention from the Ministry of Health, the rest were isolated at the school, and contact tracing was done for most of them, that for those that were taken home. The rest were quarantined within the school, isolated and quarantined within the school. So there was no need for contact tracing there. So in what our significant findings then are that during our investigation, we saw this large outbreak in this school, and it occurred at the front of a severe second wave, predominantly driven by the Delta variant. In-person meeting with more than 10 people was associated with increase in the cases, and this was not surprising, as we know that COVID is spread via super spreading events. having a symptomatic first reported case and later tracing the probable case being from grade 10A and 11A respectively could have explained the association of these two classes with reference to grade 8A. Although we might have expected the contacts with positives to be associated with positivity, this was not so, probably because of the limitation that I've mentioned above. There were no specific events or of more than 10 people, e.g. Church attendance, that were significantly associated with positivity, even though we saw that the overall variable was actually significant. Recommendations, so we made recommendations to the school and to the ministry. So we recommended that there should be a reduction in the number of pupils in the class so that we adhere to physical distancing, restrictions of the number of in-person events, placement of hand washing stations and sanitizers at each class, and symptomatic and temperature screening at every class was recommended to the management. We also wanted management to strictly adhere to masking, and we also encouraged those that were eligible for vaccination, e.g. the teachers and those pupils that were above the age of 18 to go for vaccination. So these are my references and these are my acknowledgements. Thank you very much.